A biópsia líquida é uma nova tecnologia não invasiva que permite descobrirmos uma série de informações sobre um tumor por meio de uma simples amostra de sangue. É disso que falaremos hoje no nosso grande round do Hospital de Clínicas de Porto Alegre, uma atividade em conjunta com a Faculdade de Medicina da Universidade Federal do Rio Grande do Sul. Estaremos hoje comemorando também o Outubro Rosa. E para participar dessa sessão, nós teremos os seguintes convidados. Jeffrey Wetzel, que ele é Vice President of Medical Affairs, Professor of Latin American School of Oncology. Fabiana Bettoni, pesquisadora do IEP, do Hospital Sírio-Libanês. Andréia Pires Souto Damin, que é professora e chefe do Serviço de Mastologia do Hospital de Clínicas de Porto Alegre. Doutora Patrícia Ashton Prola, que é professora e diretora de pesquisa do Hospital de Clínicas. Professora Daniela Dornelles Rosa, professora do Serviço de Oncologia do Hospital de Clínicas de Porto Alegre. E professor Jorge Villanova Biazus, professor do Serviço de Mastologia do Hospital de Clínicas. Também teremos conosco o professor Brasil Silva Neto, representando a diretoria médica do Hospital de Clínicas. Informamos que essa sessão será em inglês pelo nosso presente convidado. So welcome, Professor Jeffrey. It's a great pleasure to have you here with us today. And Andrea, the word's on you.
Welcome, everybody. I appreciate your presence, Dr. Jeffrey and Dr. Fabiana. We're gonna start with Professor Jeffrey with your lecture. Welcome again.
My pleasure, thank you. Let me share my screen. Want to be sure that the screen can be seen in one moment? All right. Does one see the screen yet?
It's just not in full mode, but we can see it.
Okay, let me try that again then. It's not in full mode. Okay, let me go back to the other screen here. It's not giving me the same option it did a moment ago, but let me see if I can get back to that.
Perfect.
Okay, finally. All right, good. All right, so I've been asked to speak about things related to breast cancer, and I could have titled this, rather than Circulating Tumor DNA and Germline Testing in Breast Cancer, something to the effect of Tools for Precision Prevention, because I really think of the evolving tools that we're going to talk about as something that is really enabling us to do things that were not even conceived of 25 years ago. So it's an honor and a pleasure. I have personally been to Porto Alegre to visit Nucleomama with Dr. Prola once many years ago. I hope again to come next time in person. It's the change now. Next slide. There we go. There we go. Okay. So, and I always start with a timeline, but not so much because I'm a mature fellow and have been around for a while, but rather because there were seminal events that gave us tools that we never would have anticipated, but are nonetheless key for how we proceed from here. Now, first, if you look around 1990, that was when Mary Claire King mapped the breast cancer susceptibility locus to chromosome 17. And at the time, it was actually remarkable because nobody believed that anything could account for something so complex as breast cancer. And yet here was a locus that could cause both breast and ovarian cancer. Within 4 years, the gene had been cloned and sequenced. And when after that period of time, after cloning and sequencing, in 1996 was the first commercial testing for a genetic predisposition in the United States. Now, the next 2 decades were exciting in my mind because not because we learned a lot about different genes, but because we learned how to take care of patients with that problem, from risk reduction surgeries to targeted therapy. Moving forward, around 2014, the beginning use of widespread use of multi-gene panels based on next generation sequencing technology. In the US, what was also relevant was the fact that Myriad Genetics had the patent disallowed by the Supreme Court. One of the few things I can agree with the Supreme Court. And that allowed multiple vendors, multiple choices for testing. But again, multi-gene panels were coming to the fore. And then one is reminded that we didn't always have a genome project. The genome project began, and in 2000, the framework was first presented. And that framework took 10 years to sequence one man's genome, and it cost $3 billion, 3 billion pieces of code. So how far have we come today when we can do whole exome and whole genome sequencing literally for hundreds of dollars in matter of weeks rather than a matter of years? And this has borne many potential tools. And a lot of this, again, has to do with the next generation sequencing. And then, of course, we have this issue of genome-wide association studies that became ever more sophisticated, giving us tools such as polygenic risk scores, which are just emerging. But today we're going to focus on things that relate. The logo on the slide is from Natera. Natera was first known for non-invasive prenatal testing, but they have their hereditary cancer testing, which is Empower. Altera and Signatera I'm going to talk about in the context of ctDNA tools. And then you can think of ctDNA. The other thing that is also potential is multi-cancer early detection. So many things are enabled by the technological revolutions that we all understood and went through. Now, this is one slide to summarize what I mentioned a moment ago. And so I'm going to spend a few moments to talk about multi-gene panel testing and the importance of germline or inherited genetics in the context of breast cancer. If you find a BRCA1 or BRCA2 result, and that's just breast cancer gene 1 or breast cancer gene 2, one of the most important things is, of course, what we call cascade testing. Testing for other adult relatives to see if they carry the predisposition. As an autosomal dominant trait, it's either there or it's not there. It's a 50% risk to have inherited the abnormal copy of the gene. Once you know what you have, then we have evidence for our advice. We have evidence for the efficacy of prophylactic or risk reduction surgery. We have evidence for the efficacy of targeted therapy, and they've moved from treatment of metastatic disease all the way to use in adjuvant therapy settings. Most people don't realize there was actually prospective data about the benefit of adding MRI surveillance to mammographic surveillance. And in fact, there was a statistical association with a decreased stage, so much more likely to be diagnosed at stage 0 or stage 1 than later stage. We'll never have a mortality endpoint because nobody would accept randomization to not receive MRI today. And then there's longstanding evidence for chemoprevention and even for the benefit of oral contraceptives in reducing ovarian cancer risk, both in the general population and in the BRCA carriers. So this is a phenomenal body of work upon which we build both medical necessity and rationale for identifying individuals at risk. Now, we had for many, many years only BRCA1 and 2 to test. And I will tell you that we didn't have it wrong. They are still the single most important component of hereditary breast cancer worldwide. They still fill out most of this pie chart. But of course, there's P10, which is Cowden syndrome, P53, which is very familiar because of the founder variant, R337H in Brazil, and particularly in the Rio Grande do Sul. But TP53 is Leishmania syndrome. PALB2, ATM CHEK2 are not syndromic as the others are, but they do cause increased risk for breast cancer from moderately high risk to moderate risk. And then CDH1, which I won't talk more about today, but causes primarily lobular breast cancer. So here we have genotype and phenotype correlations, triple negative breast cancer for BRCA1. BRCA2 looks indistinguishable from sporadic breast cancer, and CDH1 is primarily lobular breast cancer, but also hereditary, diffuse hereditary gastric cancer. Now, there are a number of other genes on these panels, most of which don't rise to beyond twofold risk. And then emerging is things like polygenic risk. Now, this is a paper from last year that I had privileged to have access to data from Myriad Genetics. And a lot of this has to do about, well, what kind of work, what kind of criteria should warrant testing? And this is a study of over 100,000 women who had unilateral breast cancer compared to almost 10,000 women who had bilateral breast cancer. And all it showed was that for women who had bilateral breast cancer, that this is the yield of multi-gene panel testing when you look at the age at onset of the first breast cancer, and obviously very young breast cancer. Not infrequently, it's high-risk genes like Brca1 and Brca2, but the moderate risk genes are there. But as you get farther along, all the way out to 75 years old, there was still a yield of at least 5% for breast cancer associated genes, with an increasing proportion that were made up of the moderate risk genes like ATM and CHEK2 or PALB2 rather than Brca1. But to me, remarkable is the yield all the way out to this age as the first breast cancer. So really the takeaway is anybody with bilateral breast cancer warrants genetic testing almost despite any other guideline, regardless of age. The other thing that was yielded from this study was an opportunity to look at why do we need to find breast cancer that is hereditary? It's actually not to treat the cancer itself outside of surgery and chemotherapy, because honestly, surgery, even a lumpectomy, is effective in virtually any hereditary cancer. It takes care of the cancer that is in front of you. It just doesn't prevent new primary breast cancers. So what is that risk? Well, here's Brca1 and Brca2. So in this study, the hazard ratio, or the odds ratio for having a pathogenic variant if you had bilateral versus unilateral disease. So Brca1 and Brca2, no surprise, long established. This is the first study to establish a risk for PALB2, even though we all suspected it and thought it was probably clinically relevant. The highest risks, no surprise here, also are things like p53 and Li-Fraumeni syndrome. It is really one of the most severe syndromes there are. There are also wide confidence intervals because of the limited number of these cases. But what else is remarkable is, and what we notice is that ATM doesn't even reach the threshold. So all the debate about using ATM to get a bilateral mastectomy is misdirected. Also, people have sometimes talked about radiation sensitivity in that context. If you're a homozygous carrier of ATM and have the syndrome, ataxia telangiectasia, yes, there's radiation sensitivity, but not in the heterozygous state. So multiple studies have now shown that there is really no evidence for either sensitivity or toxicity of radiation. So ATM should be managed, in my mind, based on the age and the presentation, and that breast conserving therapy is an equal option to any other option. Now, another study that was just recently published that I think is important is the carrier study. And the carrier study was, the principal investigator was Fergus Couch. And why was this important? Because all of the other studies that have been published, even the one I just showed you where I used Myriad's data, are high-risk cohorts that are getting commercial testing, and thus there are biases in referral. So this study was yielded from multi-gene panel testing on all of the legacy cohorts and case control groups in US. So the Nurses' Health Study, the Women's Health Initiative, the American Cancer Society's cancer prevention cohorts 1, 2, and 3, the multi-ethnic cohort. So these are unselected for family history or anything else. In fact, to some extent, they were biased against early onset because many of these cohorts may not have started enrolling till 35 or 40 years old. So the very earliest cases would have missed. But nonetheless, what this tells us is, well, Brca1 and Brca2 have the highest risks. No surprise, but you'll notice that it just reaches 50% by the age of 80. So not the 80 or 90% that we see in the high risk setting. So there are clearly modifiers of risk that we're able to get by here and see what the true genetic effect is. Further, the ATM barely rises to about 23%, CHEK2 just a little bit higher, and again, as seen in the high-risk cohorts, PALB2 intermediate. And this is really, the other thing that happened was, I like to say, we demoted a number of genes. We were concerned about, for example, NBN. Now, the Nijmegen breakage syndrome is a recessive disorder. That hasn't changed. If you inherit 2 copies, you can have that childhood syndrome. But inheritance of an abnormal allele in the heterozygous state does not cause, it causes, if it's associated with breast cancer risk, it's less than twofold. So it's been taken off of many of the, what we call the stat panels for making surgical decision-making in the context of breast cancer. It's still on the panels ultimately because of the recessive disorder, but multiple other genes have entered this space. Now, I will say that genes that are on here, I'm talking about breast cancer only, not talking about other cancers, because clearly MSH2, MSH6, critical for Lynch syndrome, BRCA1, important for ovarian cancer, but not for breast cancer, outside of triple negative and very low risk. Now, all of these things have led to changes in the guidelines, which really are becoming ever more inclusive. So that plus the Olympia A study, which, as I told you, was this movement of PARP inhibitors from the metastatic space, the maintenance space, into the adjuvant therapy space. So given a benefit for BRCA carriers, if they had received olaparib as adjuvant therapy, both a paper just came out, I think last week, in the ESMO journal on the observed survival benefit from using this adjuvant therapy. It really opens up the NCCN guidelines to essentially all stages of breast cancer if you meet that high risk criteria. And so right now, and it also changed, so it's all triple negative breast cancer, all lobular breast cancer with gastric cancer history. Metastatic breast cancer was already included because of the potential for targeted therapy, all male breast cancer. So in fact, when you look at breast cancer, the only group that is still omitted from the NCCN guideline is HER2 positive breast cancer over the age of 50, where there is no family history of cancer. And I'm pretty sure that by next year, the NCCN guideline, which I was a member of for 19 years, will probably expand, as the American Society of Breast Surgeons has, to say that all breast cancers should receive genetic testing for inherited predisposition. We are very close. It's for a number of years, all ovarian, all pancreatic, all metastatic prostate cancer. So we're getting very close to really testing all cancer. And when we use multi-gene panels, I like to use this to just describe how I view them. They can be daunting, can be intimidating because of the genes and sometimes our lack of knowledge. Our knowledge only goes so far if you haven't studied genetics specifically. But breast cancer and pancreatic cancer in the family, I'm really thinking of ATM, PALB2, and BRCA2. If it's melanoma and pancreatic cancer, but not breast cancer, it's CDKN2A, P16. If you're looking for breast cancer and colon cancer together, really it's only CHEK2 and at a very modest level. When you look at ovarian cancer and breast cancer, that's where it gets most complicated, and the most genes really can overlap. But the biggest players are still BRCA1, BRCA2, and PALB2 for breast cancer and ovarian. But again, don't forget BRCA1, RAD51D, and RAD51C. So you can see that depending on the phenotype that you're looking for, it can help to tell you which of the genes on the multi-gene panel are most relevant. So I, like all things, and like I'm sure Dr. Prola would teach you, it's about the phenotype. So in summary, at least as far as the genetic testing component of my discussion is that there are genes with well-known syndromes, so think hereditary breast and ovarian cancer syndrome or Leaf-Romany syndrome, where they have the highest cancer risks. The risk for most of the associated cancers is well-defined. Screening and management guidelines are well-defined, and there are clear implications for other family members. That is to say that if a woman inherits a BRCA mutation from her mother, she does have a very high risk. If a woman doesn't inherit her mother's BRCA mutation, she actually goes almost all the way down to normal risk. Whereas for PALB2, and more so for things like CHEK2 and ATM, there are still empirical risks that we don't explain with those moderate risk genes, where there still may be a cause for that. And that's why implications for family members for the moderate risk genes is sometimes nuanced, still necessary, but nuanced. And the risk is fairly well defined for some, but not all cancers. The most recent data on PALB2, for example, in 2019 on 500 families, finally allowed us to define ovarian cancer risk. But up to that time, we didn't have a single study that actually documented that risk. risk for pancreatic, at risk for male breast cancer, and again, reaffirmed the moderate to significant risk for breast cancer. And for many of the other genes that are on these panels that you can obtain, we call them genes of uncertain significance or genes with emerging evidence. And again, you still see variants of insignificance in all of these categories. We need to know how to treat them as uninformative. So leaving the germline testing in its purest form for a moment, I'm going to talk now about what really is exciting is this juncture between the tumor and the germline. And as I'm fond of saying, the tumor is just the germline genome with a few added features. That is the acquired carcinogenesis. But you can still see the germline in the tumor if you don't censor it. And many of the somatic tests and things that we look at actually censor the germline signal in order to interpret what's in the tumor for targeted therapy. But the reality is that we can't ignore that. Identifying a Brca1 or 2 mutation will give you access to PARP inhibitors. Identifying the signature of the effect of those genes, homologous recombination defect, will also get you access. So somatic, inherited, acquired, inherited, they both work together. And we used to argue for so long to get microsatellite instability testing done on tumors because we wanted to identify Lynch syndrome. But now, because of the advent of immunotherapy, it is at least now more uniform in precision medicine to obtain microsatellite instability, which again can both identify the acquired state and the inherited state. Now, Dr. Slavin and I worked with Garden. So now we're talking about that tool that we're emerging and moving to, which is cell-free DNA, or sometimes called circulating tumor DNA. And this is really DNA that is in the plasma. When you in a Streck tube, what happens is there's a preservative that helps to prevent the white blood cells, other nucleated cells, from lysing and releasing the DNA. So that's the only secret to those tubes, is that it helps to limit the germline signal in order to pick up the signal at the bottom here, which is the dissolved DNA from the tumor that is degrading. And what we show here is simply that if you look at the variant allele fraction or mean allele fraction, and it's usually very low in proportion to the germline signal in the tumor testing when you're using ctDNA. But if you look carefully, you find variants that are actually at 50% variant allele fraction, which is exactly what you expect for heterozygous. So all of these are clearly germline findings in this test using their data. And it's not until you get to extremely metastatic disease, the yellow dots trailing up here, where you see that it finally starts to cross the variant allele fraction threshold, as it were, because of widely metastatic disease. So the absolute burden of ctDNA. But in a set of 10,000 unselected patients, we found genes that were germline among the lung cancers, the breast cancers, the colorectal, the prostate. We found at least 151 putative germline mutations. Now, this set is biased. There's no ovarian cancers in here because there wasn't a reason for doing this test. And their gene test was not complete. It didn't even include PALB2. So this is an underestimate of what one might find when applying these technologies in that setting. The other thing, interestingly, that can come out of the cell-free DNA testing, because you're sequencing these genes, is you sometimes can find the BRCA reversion mutations. That is, you have the mutated version and the reversion mutation, which can mediate resistance. Now I'm going to segue to where this technology really started. So I wanted to highlight that non-invasive prenatal testing using next-generation sequencing and cell-free plasma was both an innovative and a disruptive technology. In 1 year of implementation, that is the ability to do a blood test in a pregnant woman to identify trisomies, the things we normally would screen for with amniocentesis, was a really signature implementation. It displaced 80% of amniocentesis use in the US in its first year of introduction. This is phenomenal as a disruptive technology. But ironically, it was also the very first liquid biopsy for tumor detection in the mother, because they went there looking for aneuploidy, and they found aneuploidy but it wasn't the baby. It was a cancer. And so this is an example of that here, simply showing that they compared what was detected on the next generation sequencing of the plasma DNA here to looking for the abnormal DNA, but they found the DNA of the baby and they found DNA of a tumor. And this is simply showing that the tumor pattern was the same on chromosomes 9 and 6 in both the tumor and what they detected in the cell-free DNA, really establishing that you could detect tumor DNA in cell-free DNA. So I like to bring this up because many people, the field has gone so far forward and there are so many dominant players, but at least as far as non-invasive prenatal testing, there is no company other than the one that I joined 8 months ago, Natera, that does 50% of the non-invasive prenatal testing in the US. Now, how good are our tools for surveillance? And so this is really a provocation to think about, well, in patients treated with neoadjuvant therapy, achieving a pathologic CR generally knows favorable prognosis, but you basically have to wait till you take the tumor out or the tumor area out, do the pathology to see the complete response. So you don't know what's gone on between the beginning and the end of that, although imaging does give us some insight. Current tumor markers are abysmal. They're terrible. CA2729, CA15-3, they suffer from poor positive and negative predictive value, and really have, despite that, we've used them, but literally they're not great tools. Imaging tools have been the standard, both to judge clinical trial efficacy, etc., but sometimes can be unreliable, difficult to read, and sometimes there is scarring, and there's structural things that we can't be sure are a tumor, and don't necessarily get down to molecular disease. So these are the concepts that we wish to address. So ctDNA as a cancer biomarker. So it's a highly specific and dynamic blood-based cancer biomarker. The dynamics can be used to assess disease burden in real time. That is, as cells divide. This is our infinitely recycling body. Our bodies take every cell. There's no cellular elements that are wasted. And as cells die, that DNA is absorbed into plasma, ultimately broken down, and the basic components are recycled. So it's not surprising that it would be in the plasma. It's just the next generation sequencing that enables us the chance to see it. Now, often there's a distorted blood or distorted interface with the vasculature, which allows more leakage. There's often poor blood supply in the tumor, which causes necrosis. And these things then can cause that DNA to be leaked into the plasma, where it can be monitored. And it only lasts a few hours in the plasma. So it does have to be preserved and collected appropriately. But this is the principle where we're working from. You basically segregate the cellular elements, you isolate the plasma, and that's where we look for that. Now, there are other technologies that have come to fore previously, such as circulating tumor cell technologies, but those flow sorting technologies were really expensive and difficult to use, even if they did have correlations. So you can imagine this could be used for early detection. So think of multi-cancer early detection therapies like our treatment or tests like GRAIL, their Galleria test. We're developing such testing as well because of our prowess with CT testing. But you could identify the cancers before they're imaging available. You can look at the response to neoadjuvant chemotherapy because the assays that we use can actually be put into play quite quickly. And they can be used to monitor the treatment and then surveillance for early recurrence. Now, minimal or molecular residual disease detection is widely used now in hematologic malignancies. Finding the BCR-ABL translocation in CML is now used as the absolute marker of when to stop treatment and when there is recurrence. MRD in cancer is really cancer persisting after treatment that can't be detected with current imaging, and MRD may be used in solid malignancies to more accurately monitor tumor levels. This is just showing an example where you might find this threshold of detection and the threshold of detection here with clinical means. And you can see that they will correlate, albeit here you would know that you could add adjuvant therapy back. Here, you know, they may be thought to be cured. So we go on from here as the potential. Now, how is this done? Well, basically, they take the primary tumor. It has multiple genetic changes. You assay that tumor, you identify genetic changes, and then you create a specific assay. In this case, we call it a bespoke assay for that individual. And I'll go on to show what that means. And then you use that PCR test to do quantitative assessment of the presence or absence of that tumor molecule. And what's interesting to me is that they can actually get down, at least in our hands, down to 1 molecule of tumor DNA in a tube of blood. So basically, they do this sequencing. They use whole exome sequencing of tumor and matched normal DNA. They find 52, there's an average of 50 to 200 somatic mutations in every one of these analyses that are originating in the tumor. And what's interesting here, and this is important, they don't select things like EGFR or other specific targets for therapy, because therapy may cause that clone of cells to drop out, but rather clonal mutations that won't necessarily move or change based on the pre-treatment pressure. And so they'll select, in our test, 16 to 20 single nucleotide variant markers that are unique to each tumor, and then they use those to create the assay. And I'm not going to talk in great detail, but there are so many studies now coming out that are incredible. And so when you look at this is in colon cancer, where we already have CMS codes and indications. In colorectal cancer, this really is already on the verge of altering therapy, because if you have stage 2 colon cancer, a stage that we've always been in conflict about whether to give adjuvant therapy, we now know that if their ctDNA goes to 0 after surgery, that they will do equally well to those who have persistent DNA, but without any chemotherapy. So we know not to give chemotherapy in that state. That is akin to Oncotype DX, where we find, but Oncotype DX simply defines the behavior of a breast cancer, that if you give endocrine therapy, will you do okay, or do you need to add chemotherapy? Whereas this is actually literally testing whether the tumor still exists in the body. So there are multiple studies for colon cancer, non-small cell lung cancer, breast cancer. Recent study just came out last week about monitoring triple negative breast cancer during neoadjuvant chemotherapy. So again, a direct correlation between ctDNA status and recurrence status. And then muscle invasive bladder cancer I mentioned earlier as well. So here's an example to triple negative breast cancer MRD assessment. You can see how the ctDNA might change over the course of therapy. And what you find out is that here we are with the evidence potentially of recurrence. And they receive chemotherapy, result of that, and the recurrence going down. And in this case, actually, the Signatera test prompted a CT scan that then showed the measurable suspicious findings, because as these tests are still in evolution, I don't know of any clinical guideline yet that says you can use that alone. We're still in the correlative phase, but it's pretty clear that these markers change well before imaging. Here's case continued with, again, where MRD is detected, and then you can see how with each line of therapy, you know that in this case, this new line of therapy is working until it doesn't. And then it obviously is coming back up, and it all follows along the same pathway. Now, Signatera can detect recurrence earlier than traditional tools. So this is simply looking at patients who had recurrent disease versus not, time since surgery. And when you look at the which said it better, it's kind of like who wore the dress better. The lead time over radiographic recurrence was at least 10 months. So at least 10 months prior to radiographic recurrence, you could detect the ctDNA. So again, highly sensitive, interesting tools. Now, there are now studies that have integrated ctDNA. So in this study, the LEADER Part 2 study, it's ER-positive disease treated with CDK4, CDK6 inhibitors earlier versus later, based on MRD, which I think is exactly the kind of generation of tools studies we need to do now. But the idea is that when there's surveillance, that you either react to that ctDNA, the molecular relapse, and start treatment then, or you just continue with endocrine therapy. And basically, there are randomized trials to integrate these MRD tests in the treatment paradigm, and will help us to understand that, yes, does treating earlier at the first evidence of ctDNA positivity have a benefit as compared to waiting till it's clinically apparent? So there are guidelines. So I just want to say that, again, we're going to transition now to real world evidence from your colleague who is going to present the next part of this conference. And so by way of summary, there are guidelines for screening for MRI, risk reduction, and emerging indications for genetic therapies, and Brca testing influences surgical decisions in a risk-appropriate way. Well-established science. And I will say that when I came to Porto Alegre, we went to Nucleomama because, to her credit, Dr. Prola and her team had been addressing the underserved and those who had no access to testing. It's still quite limited, of course, across much of the developing world, but this is something that was appropriate, and you could still use family history as a surrogate for identifying syndromic cases at the time. But really, we need to get next generation sequencing to all who can use it. Appropriate to go well beyond BRCA1 and 2, and I think that PALB2 and CHEK2 are probably the most relevant genes beyond these others and outside of the syndromic genes. Surveillance and prevention can improve survival in at-risk individuals, but the protocols will need to be adapted to the lower risk of the moderate risk genes. You don't do an oophorectomy in a CHEK2 carrier. There's no ovarian risk. You don't need to do risk reduction surgery necessarily, though it may, in some circumstances, be chosen. So we have to adapt our protocols more sensitively to the actual risk, and that's where things like the carrier study help. ctDNA is a highly sensitive and specific biomarker for molecular residual disease and has potential clinical applications in areas characterized by uncertainty as it pertains to treatment planning. The utility of MRD after surgery in early stage colorectal, breast cancer, muscle invasive bladder cancer is already now well established. And it'll help us to understand who will benefit from adjuvant therapy. And then again, it helps us to identify tumors earlier in longitudinal surveillance. And also we'll understand whether in neoadjuvant therapy, it'll help us to treat better and more effectively and to be able to change therapies if the one we're using isn't working. And to have a sensitive marker of that is dynamic is important. I will say that there are other things like the liquid biopsy to identify tumors, and you'll hear more about how these things are used to identify markers for therapy. So I want to thank you so much for your attention for this phase of this. And I'll close with what is, I think, most important, which is my friendship with Dr. Prola. She was the first person from outside the United States to come through the intensive course at the City of Hope, which I had created with Kathy Blazer. This is Kathy Blazer, my dear friend and partner in this project, and on one of our many reunion conferences to continue learning, because we never stop learning. And again, I'm so proud of Patricia as she has rose to the national and international stage. This is our friend Fumiola Patti. This was one of the AACR annual meetings some time ago, and Patricia leading one of the sessions. And again, here she is, not just back to help us to learn more, being a speaker in one of our conferences, but bringing colleagues who you all know to the City of Hope to take the course and spread the word. So paying it forward, and no surprise at all from when this bold individual bullied their way into my course to begin with. But no regrets, only celebration. Thank you very much.
Thank you very much, Jeffrey, for the brilliant lecture and educative. Fabiana, please, can you start?
Vocês conseguem me ver? E a apresentação também?
Só botar em modo apresentação, Fabiana.
Está ok?
Ok, agora.
So I'd just like to thank the organizers for the invitation. It's a pleasure to be here to participate in this educational session. And I'll switch to Portuguese to give my talk. Então, eu vou falar um pouco para vocês sobre um dos projetos que nós desenvolvemos no Hospital Sírio-Libanês. Ele já está numa fase final de publicação dos dados, mas dando um pouco de continuidade ao que o Dr. Jeffrey apresentou com relação a detecção de DNA tumoral circulante, né? Então, eu vou fazer uma breve introdução sobre biópsia líquida, começando com a definição do conceito, né, de biópsia líquida. É um conceito relativamente novo, então, acho que vale a gente reforçar. Então, a biópsia líquida é a detecção de células tumorais circulantes, de ácidos nucleicos circulantes, seja DNA ou RNA, e de vesículas extracelulares, como os exossomos, em diferentes fluidos corpóreos. Então, além do sangue, nós podemos detectar também na urina, no líquor, na saliva, em efusão pleural, então em diferentes fluidos corpóreos. A biópsia líquida é uma metodologia altamente sensível, específica, minimamente invasiva, e ela possibilita a monitoração da dinâmica do tumor, né, na dinâmica de evolução clonal, aí, através de coletas seriadas durante todo o curso da doença ou durante um tratamento. E ela pode ser utilizada como uma metodologia complementar às biópsias teciduais em diversas situações clínicas. E aqui vale a gente ressaltar que a biópsia líquida, ela vem para complementar a biópsia tecidual, né, para contornar algumas limitações associadas à biópsia tecidual e não para substituir. E eu acho que uma das principais limitações associadas às biópsias teciduais é com relação à heterogeneidade intratumoral, né. Então, nós sabemos que existe tanto uma heterogeneidade espacial quanto temporal, né? Se nós pensarmos no tumor como uma população heterogênea de células, né, heterogênea geneticamente falando, se nós analisarmos uma pequena região desse tumor, por uma amostra de tecido, isso não vai representar toda a heterogeneidade tumoral presente naquele tumor. Então, seja num cenário de um paciente com um tumor primário ou um paciente com múltiplos focos metastáticos, uma análise de uma amostra de sangue pode, então, nos indicar aí toda a heterogeneidade genética presente nesses tumores. E quando a gente fala de uma heterogeneidade intratumoral temporal, aí nós temos que pensar que ao longo do tratamento, ao longo do curso da doença, essa população de células, ela vai se modificando, né, ao longo do tempo, de forma que você tem que ir acompanhando isso através de coletas seriadas e observando toda essa variação de clones, né, indicando aí a heterogeneidade genética se modificando ao longo do tempo, né. Então, clones que vão sumindo, né, associados, por exemplo, à sensibilidade a algum tratamento, como o surgimento de novos clones associados à resistência ao tratamento. E falando um pouco mais aí sobre DNA tumoral circulante, eu acho que já foi muito bem explicado pelo Dr. Jeffrey, mas eu só queria aqui chamar a atenção para uma característica muito importante do DNA tumoral circulante, que é o fato dele carregar alterações específicas do tumor, alterações genéticas, né? Então, é isso que vai permitir com que a gente faça a distinção do DNA que é originário de uma célula tumoral do DNA que veio de uma célula normal. Tá? E quando a gente pensa nas aplicações clínicas das biópsias líquidas, nós podemos dividir tanto no cenário de pré-tratamento como de pós-tratamento. No pré-tratamento, nós temos, então, tanto o screening como a definição, então, de uma conduta terapêutica com a identificação de biomarcadores, né, então, aí no momento de diagnóstico da doença, e no momento de pós-tratamento, nós temos desde o monitoramento e a detecção de doença residual mínima, como já foi explicado na aula anterior, né, a avaliação e o acompanhamento da evolução, da dinâmica, né, de evolução do tumor ao longo do tempo, ao longo de um tratamento, e aqui, em especial, o monitoramento, seja da resposta ao tratamento, como da detecção precoce de resistência ao tratamento, através da identificação de mutações associadas à resistência a um determinado tratamento. E é essa aplicação clínica que eu quero destacar para vocês, nesse trabalho, então, que nós desenvolvemos no hospital. Foi um trabalho que começou já há alguns anos, e o nosso objetivo, então, era mostrar que, através da biópsia líquida, nós conseguíamos detectar precocemente a resistência ao tratamento, ou seja, indicar, através da biópsia líquida, que aquele paciente já não estava mais respondendo àquele tratamento. Hoje isso parece uma questão muito óbvia para alguns tipos tumorais, né? A gente já tem aí inúmeros trabalhos publicados mostrando que realmente isso é possível, mas no momento que a gente começou esse estudo, a gente ainda tinha poucos trabalhos na área, né? Então, esse estudo, ele se dividiu em 3 subprojetos. Todos eram pacientes metastáticos, então nós tínhamos um projeto com pacientes com câncer de pulmão, não pequenas células, um grupo de pacientes com câncer de mama positivos para o receptor de estrógeno e pacientes com câncer coloretal. Para cada grupo de pacientes com diferente tumor, esses pacientes eram tratados com drogas específicas, e nós já sabíamos, né, nós já tínhamos isso muito bem documentado, né, com base na literatura, quais eram as alterações genéticas que estavam associadas à resistência a esses tratamentos. E foi isso, então, que a gente fez nesse estudo, foi monitorar e procurar por essas alterações nesses pacientes. Então, quando o paciente iniciava o tratamento, nós começávamos, então, com uma coleta de sangue, essa amostra era processada em até 2 horas, e o plasma era congelado, e no momento, então, da progressão da doença, nós, então, extraíamos o DNA circulante, né, e avaliávamos a detecção, então, de alterações genéticas que estavam associadas, poderiam estar associadas à resistência ao tratamento específico daquele paciente. Tá? Então, desde o momento de inclusão no estudo, quando ele iniciava o tratamento, nós continuávamos, então, acompanhando esse paciente através de coletas seriadas, e no momento que o clínico, então, nos indicava uma progressão de doença, nós fazíamos uma análise retrospectiva de todas as amostras que nós havíamos coletado, para, então, avaliar se nós conseguíamos identificar uma resistência ao tratamento precocemente, ou seja, antes da detecção clínica e por exames de imagem. Então, para o grupo, né, dos pacientes com câncer de pulmão e câncer coloretal, nós iniciamos antes do grupo de câncer de mama, então nós já temos alguns trabalhos publicados na área, e hoje, claro, que eu vou focar para vocês é com relação ao nosso estudo com pacientes com câncer de mama metastático positivos para o receptor de estrógeno. Então, a gente sabe que os pacientes com câncer de mama, os tumores, né, de mama que expressam receptor de estrógeno representam aí 70% do total desse tipo tumoral, e o receptor de estrógeno, então, quando se liga ao hormônio, né, ao estrógeno, ele se dimeriza, se liga a regiões específicas no DNA, ativando, então, a transcrição de genes que vão promover, então, a proliferação e a sobrevivência celular. Quando a gente pensa no cenário de tratamento dos pacientes com esse tipo específico de tumor de mama, nós temos 3 classes de drogas. Os inibidores de aromatase, são drogas, então, que inibem a síntese do estrógeno, né, a conversão de andrógeno para estrógeno através da inibição da enzima aromatase. Nós temos drogas, então, que vão modular o receptor e drogas que vão degradar o receptor de estrógeno. Tá? Então, nós sabemos que existe um número significativo de pacientes com câncer de mama que expressam receptor de estrógeno e que vão desenvolver metástase depois de uma exposição prolongada, né, ao tratamento endócrino. E já no cenário de pacientes com doença metastática, que inicialmente respondem ao tratamento, invariavelmente eles vão progredir com o desenvolvimento de uma doença resistente e hormônio independente. Então, diversos estudos já demonstraram que mutações no gene ESR1, que é o gene que codifica o receptor de estrógeno, podem surgir após o início da terapia hormonal, podendo, então, ter um papel importante, seja na falha terapêutica, como na progressão da doença. E essas mutações no gene ESR1, elas ocorrem frequentemente numa região, num domínio, né, do receptor de ligação, então, ao hormônio, né, ao estrógeno, e essas alterações, elas vão fazer com que esse receptor, ele fique ativo constitutivamente. Então, de uma maneira que, independentemente da ligação do ligante, esse receptor vai ficar ativo. Isso porque essas mutações, elas levam a uma alteração da conformação do receptor, fazendo com que ele fique, então, numa conformação ativa. Dentre as alterações, né, as mutações já descritas, né, em SR1, no momento em que nós iniciamos o estudo, as mais frequentes e mais descritas na época compreendiam esses 3 aminoácidos e foram, então, as alterações que nós monitoramos nos nossos pacientes. Então, inicialmente, nós tínhamos 20 pacientes incluídas no estudo, nós tivemos perda de 5 pacientes, né, por perda de segmento, uma paciente faleceu, e nós ficamos, então, com 14 pacientes que nós acompanhamos. Aqui a gente vê que o número de coletas, né, variou muito entre as pacientes. E aí, dessas 14 pacientes, até o momento em que nós encerramos a parte de coleta, né, de amostras do estudo, nós tínhamos 6 pacientes que não tinham progredido e 8 pacientes que tinham progredido ao tratamento com terapia hormonal. Então, dessas 8 pacientes, nós avaliamos, então, a presença daquelas 5 mutações em SR1, as mais frequentes, como eu falei para vocês, e nós vimos, então, observamos aqui uma frequência alta de mutações em SR1 nessas pacientes, ou seja, das 8 pacientes que progrediram, 5 tinham mutação em SR1. Se nós olharmos para os dados da literatura, isso nos chama atenção, porque na literatura o que é descrito é que de 25% a 30% das pacientes que progridem ao tratamento com terapia endócrina tem a presença da mutação em SR1, ou seja, o nosso dado aí foi superior aos dados da literatura. E aqui uma coisa que nos chama a atenção é que, após o início do nosso estudo, surgiu então a possibilidade dessas pacientes serem tratadas com uma nova classe de drogas, que são os inibidores de CDK, né, que também foi descrito um pouco, explicado um pouco pelo Dr. Jeffrey. Então, só para a gente lembrar, a CDK tem um papel essencial no controle, na regulação do ciclo celular, então, a sua desregulação ou superexpressão leva, então, a uma proliferação anormal das células, né, e possível desenvolvimento de um tumor. Então, o controle da atividade, né, dessas CDKs, através da sua inibição, pode levar, então, ao controle aqui, um possível novo tratamento para essas pacientes, né. Então, a gente tem aqui, hoje, já no cenário atual, uma combinação dos inibidores de CDK e terapia endócrina como um tratamento já padrão, né, de primeira linha para pacientes com câncer de mama hormônio positivas no cenário avançado e metastático. E o que é importante a gente ressaltar aqui é que o tratamento combinado, ele não evita o surgimento das mutações em SR1, mas ele se mantém efetivo a despeito da presença dessas mutações. Tá? Então, das 14 pacientes que nós tínhamos no nosso estudo, 9 foram tratadas com tratamento combinado, e das 8 que tinham progredido, 5 foram tratadas com o tratamento combinado. E dessas 5 eu vou mostrar, então, para vocês com mais detalhes, 3 dessas pacientes aqui, como foi, então, a nossa análise nesse estudo. Então, essa primeira paciente aqui nós acompanhamos por aproximadamente 4 anos, então, a gente tem aqui 28 coletas, né, que nós analisamos dessa paciente, e aqui o que a gente destaca é que foi detectada, então, progressão clínica da doença em junho de 2021, mas 10 meses antes, como a gente pode ver aqui, nesse ponto aqui, em agosto de 2020, nós já detectamos a presença da mutação em SR1 no DNA tumoral circulante, indicando aqui que a gente já tinha uma progressão de doença quase um ano antes da detecção clínica, né? Essa linha tracejada, ela indica para a gente o nosso limite de detecção, né? Então, todos os pontos acima dessa linha indicam positividade da presença, né, da detecção dessas alterações no DNA tumoral circulante. Nessa outra paciente aqui, a gente, após um ano, né, e meio do início do tratamento, essa paciente apresentou uma progressão locorregional, e aqui os dados de biópsia líquida corroboraram. Nesse mesmo momento nós tínhamos uma coleta para analisar, onde nós detectamos aqui um aumento, né, dos níveis de DNA tumoral circulante, através da detecção dessa mutação em SR1, mas o mais interessante é que um ano antes nós já havíamos detectado a presença dessa alteração no DNA tumoral circulante, indicando aqui que essa paciente já estava, né, não respondendo bem ao tratamento nesse momento aqui, né? Essa paciente, ela fez uma radioterapia, após o término do tratamento, ela fez um PET-CT que indicou resposta ao tratamento, o que, numa coleta seguinte aqui, nós corroboramos com esses dados aqui, também mostrando que nós não conseguimos mais detectar a presença dessa alteração no DNA tumoral circulante da paciente. E por último aqui, eu trago essa outra paciente, que é um cenário um pouco mais complexo, eu diria, porque é uma paciente politratada. Essa paciente, ela iniciou o tratamento combinado e ela progrediu em 5 meses, o que para a gente indicaria aí a presença de uma resistência primária, né? Então, quando a gente fala da presença das mutações em SR1, a gente associa com uma resistência secundária ou resistência adquirida. né? Então, essa paciente seguiu para um outro tratamento, né, com fulvestranto, e aí, no momento de progressão a esse tratamento, ao fulvestranto, nós detectamos aqui a presença da mutação, de uma mutação em SR1, e mais do que isso, através de uma análise retrospectiva, nós observamos aqui a presença, a detecção dessa alteração 9 meses antes da detecção clínica e radiológica de progressão da doença. Então, mostrando aqui, mais uma vez, que nós conseguimos detectar precocemente a progressão de doença. Aqui, nos tratamentos que se seguiram, a gente vê uma correlação entre os dados, né, a resposta radiológica e a resposta, né, os dados de medida aqui, de DNA tumoral circulante, e um dado muito interessante é que nós fomos avaliar essa amostra aqui do momento de progressão ao tratamento combinado, né, de inibidor de aromatase com inibidor de ciclina, CDK, em que nós não tínhamos detectado a presença, né, de mutação em SR1, nós seguimos para uma análise de sequenciamento DNA tumoral circulante com um painel de 151 genes associados ao câncer. E aqui nós identificamos uma mutação em RB1, né, já se sabe que mutações em RB1 estão associadas à resistência ao tratamento com inibidores de CDK, então é possível que essa alteração identificada em RB1 esteja associada com a resistência primária observada no tratamento aqui nessa paciente. Então, com isso, a mensagem que eu queria deixar para vocês é que a biópsia líquida é uma metodologia altamente sensível, específica, né, e que no cenário de pacientes com câncer de mama, especificamente positivos, né, para o receptor de estrógeno, que são tratados com terapia combinada, terapia endócrina mais inibidores de CDK4 e 6, o monitoramento da presença de mutação em SR1 pode ser utilizado para monitorar resposta ao tratamento, resistência adquirida ao tratamento, antecipando, então, a resposta radiológica e a falha terapêutica que essas pacientes podem apresentar. Então, era isso que eu tinha para falar para vocês. Eu gostaria de agradecer aqui a todo o grupo de pesquisa translacional, em especial a doutora Ana Maria Camargo, ao grupo de pesquisa clínica e do REDCap, que, desculpa pelo barulho, que nos ajudou muito na questão de coleta das amostras, o corpo clínico do hospital, né, do Centro de Oncologia, que nos ajudou com a inclusão das pacientes no estudo, e ao Dr. Marco Gellinger, do ICR, em Londres, e todo o seu grupo, que nos ajudou com a parte de sequenciamento do DNA circulante. Também gostaria de agradecer à FAPESP, ao Instituto Ludwig e também ao hospital pelo financiamento desse estudo. Muito obrigada.
Obrigada, Fabiano. Excelente palestra. Agora a gente pode começar com as perguntas. Eu vou começar com uma pergunta para ambos vocês.
Andréia, teu microfone está fechado.
I'm sorry. I like to do a question for both of you guys. Today, ctDNA testing, it's already demonstrate clinical utility in late-stage breast cancer. Do you think someday we can use ctDNA in early breast cancer or even for screening?
I think it's pretty clear that that's possible when you look at multi-cancer, although I will say that the available multi-cancer early detection tests, for example, Gallery and things, there are some limitations in terms of their sensitivity. The other thing, when thinking about ctDNA monitoring of breast cancer, I would think, I'll call it the weak spot. It's what we've all encountered over so long, which is ER positive, so hormone receptor positive disease, which often has such an indolent course. As you know, it's not uncommon for us to have somebody who might go 5-10 years without clinical evidence of recurrence, and then there's a recurrence. So if the ctDNA went to 0 or close to 0, when do you put the flag up and say we won, it's cured, as compared to having to be sanguine about how we interpret this. So, nothing clinically detectable or treatable now, but, I think those are some of the bigger challenges. For the aggressive diseases, like early stage triple negative breast cancer, things like that, where within 2 years, the situation is clear. You either won and we've cured them or not. I think that the tools are already immediately very potentially useful. I think the other is that in order to get into guidelines, we need to be able to show that, one, can you get equal result with less treatment? So can somebody who has what looks like a high-risk tumor, but surgically it worked well, or the first 3 cycles of chemotherapy brought it to 0 on ctDNA, can we stop and then monitor? And my gosh, ask any woman or man who receives chemotherapy, less is more. It's so much better not to be treated. So I think the biggest impact, the earliest impact, is going to be giving less therapy, not giving more, because that'll tell us that we can safely do so. But I do think that over time, it's going to both help us early detection, because being able to detect these tumors before their imaging is positive by 10 months. However, it also provokes the problem of, well, what are you going to use for screening to find where it is if you have an early positive signal, but your conventional imaging has failed? So we have a lot of work yet to do to marry the conventional imaging, or whatever you use. Do you use whole body MRI? Do you use PET-CT? We don't know yet. I think these are the provocative questions.
I totally agree with Dr. Jeffrey. I just like to add that we have to think that the concentration of ctDNA varies a lot among patients. And when you think in the early stage scenario, the concentration will be lower because you have to think that the concentration of ctDNA it's proportional to the size of the tumor, to the vascularization, to the stage of the disease. So in the scenario of early stage tumors, will have a lower concentration of ctDNA. And when we think the methodologies that we have now to analyze and to detect ctDNA, I think we have to improve more, to have more sensibility to detect in this scenario. So it's a challenge that we still have.
The other thing I would add to that is it's different to detect recurrence and then find it by imaging than it is to detect de novo disease, because I can tell you, as having done a lot of high-risk surveillance for BRCA carriers, the signature early find to me is non-mass enhancement on a breast MRI, where you get the biopsy done and you never would have seen it by any other imaging, and it turns out to be ductal carcinoma in situ, this absolutely curable earliest phase. And so I would say that for multi-cancer detection, I think there's your benchmark. Can we pick it up as soon as that or sooner, at least for that kind of screening?
Thank you. Patricia.
I wanted to place a question about screening, which I think has been answered already. And I wanted to ask a little further down this question, in terms of high-risk breast cancer patient screening, how far do you think is a solution for screening, for instance, our hereditary cancer patients? 5 years, 10 years? Because probably what we see ahead of us is that it likely will be very sensitive and perhaps even lower cost and less trouble for our patients if we could assume screening through liquid biopsy, perhaps together, or even in certain situations substituting imaging. Do you see this as a reality anytime soon, or are we very far from that?
Well, it depends how one defines far. For patients' perspective, never soon enough. But I think that I think we measure this within the next 5 years, for when at least there'll be certain implementations. Already, we have a test in the United States that is offered by Exact called Cologuard, which isn't equal to colonoscopy, but pretty close. It's not going to pick up an early adenoma, which we know in Lynch syndrome removing the early adenomas actually reduces risk, and you can't do that without colonoscopy. So we already have an example of a blood test that has disrupted or displaced colonoscopy potentially with similar sensitivity. So I'm very encouraged that this is a model for what we hope to do in other settings. We still have to resolve, Patricia, this conundrum of you find something with ctDNA, how do you find the correlative tumor? So, Leishman syndrome, think about it. We've given up. We're doing the whole body. We don't even say one area or another. We do the entire body because of the multiplicity of systems. It's tell you what, as soon as we can do a good job in Leishman syndrome, we'll probably be able to do a good job pretty much everywhere else. How's that for a benchmark, right?
Excellent response. Thank you very much.
I did notice on the what's up. I don't know why I was monitoring it, but I saw a question there about multi-gene panels that I can address. And it really is something that I got all the time. Every time I wrote a grant about implementation of risk assessment in a country with limited healthcare resources, Colombia, Peru, Mexico, where I've been doing most of my work other than our collaborative work in Brazil, there's the question of, well, if we test all breast cancer patients and find all these variants, first off, what are we going to do with them? Can we afford to test their relatives? And I would just turn that question around and say, we can't afford not to take care of their relatives, because the sooner we get to prevention, rather than waiting for people to get cancer and then struggling with the death and everything from those and all the expenses of treatment, adjuvant therapy for one breast cancer, adjuvant therapy for ovarian cancer, treatment of ovarian cancer, it's at least $100,000 minimum in any country in the world. Even with the cheapest delivery system, it's over $100,000. So if I can use a $250 test and determine who needs to therapy, who can get prevention, and we know that it's not cheap, but risk reduction mastectomy is highly effective. Oophorectomy is the single most important intervention in the high risk, because it both eliminates most of the Müllerian tumor risk, and if done post-childbearing but before menopause, it also reduces breast cancer risk. So a single one-time intervention, risk reduction and elimination of risk. We can't afford not to implement such testing for relatives. It is the pathway to population health where we are effective at reducing cancer. And it allows us, the other analogy I've used, by the way, I got a criticism on one grant that, why don't you fix mammography in Mexico? Because only about 19% of people get mammography as a screening on a regular basis. And I said, that's crazy. I would rather screen one BRCA carrier than probably 50 average risk women. I'm so much more likely to find the tumor. And so it's a way for us to allocate resources in an intelligent fashion, that when the resources are limited. It really helps us to stratify and to strategize our use of resources, rather than one that exceeds our capacity.
Yeah, it's almost the same reality in Brazil. It's a lower rate of mammography here, too. Okay, Luciana, our time is done.
Yes, our time is over. So thank you so much, Jeffrey and Fabiana. I think that we had a beautiful session with many new concepts for all our community. So it was important to have this kind of session in our hospital. So thank you so much, everybody. Andrea, do you want to?
And I'd like to thank you very much. It's very brilliant lectures, and I learn a lot too, because I'm a surgeon, but I like molecular biology, and I think is the future. The future is like biopsy. I think is the future. We're gonna see, I think. Thank you very much for being with you.
Okay.
A pleasure and honor.
Bye-bye.
Thank you. Bye-bye.
Bye-bye. Thank you.